Hello and welcome to today's webinar here, the Midwest Concussion Clinic's virtual lunch and learn that happens once a month. My name is Matt Campbell. I'm the owner of the Midwest Concussion Clinic. The Midwest Concussion Clinic is a 100% virtual concussion clinic that is brought to you by myself and kind of looking at the treating of acute concussions as well as persistent post-concussion symptoms in the comfort of your own home. With March being National Athletic Training Month and Brain Injury Awareness Month, I wanted to put together a webinar that looks at the total kind of big picture of what the role of the athletic trainer is during concussion management. The four key objectives that we're going to talk about today is number one, we're going to talk about the importance of concussion education and awareness, ways the athletic trainer is in charge of and involved in the education overall of concussions and with athletes and injured workers. The second thing that we're going to look at is concussion evaluation and diagnosis. What goes into the evaluation of a concussion, a sports-related concussion, what goes into an industrial-related concussion, and kind of how we look at diagnosing concussions as a whole. The third thing that we're going to look at is bridging the gap in concussion management. It's important for athletic trainers to bridge the gap in the sports medicine team, and bridging the gap during concussion management is no different. So we're going to talk about how athletic trainers are involved in bridging the gap in all parties involved in concussion management. And finally, we're going to talk about post-subjective and objective recovery of concussions. So what happens, how do we determine somebody and how they recover? And then we're going to talk about the responsibility of the athletic trainer after somebody is returned back to the field or back to their regular work environment. Concussion education is one of those things that I pride myself on, and kind of it's my soapbox in terms of something that is underutilized in the sports medicine world and the industrial medicine world. Education is not a one-time process. Concussion education, concussion research, everything is evolving surrounding concussion, so it's important that we evolve our mindset and kind of continue to provide our concussion education and awareness overall. When we talk about concussion education, who really needs the education? I'm going to be perfectly honest with you. I have a business completely surrounding concussions and concussion management, and I am very aware that nobody really cares about concussions until something happens, or until somebody that they know is recovering from a concussion, or if they're involved in the concussion world. So when we talk about the needs of concussion education, I've kind of broken it down into common and uncommon parties. Okay, the common people that we understand, most people understand that they need some education when it comes to concussions is number one, the athletic training staff. Right? If you're in charge of helping them navigate the concussion world and the concussion recovery world, you better have a good understanding or a good idea of what needs to be addressed or what needs to be covered during, with a concussion. Okay. The second thing is athletes. Athletes need to understand what's happening, what the risks are, what the potential injuries are, things that we need to be on the lookout for, and kind of what it involves when an athlete gets injured. The third people that are common into this party are coaches and parents. Okay, here in Indiana, coaches have to go through what's called the heads-up concussion education process through the CDC, and I'm going to be perfectly honest with you, it does the bare minimum, right? So when we start talking about the role of athletic trainers in concussion education, parents and coaches are the primary focus that we need to kind of have in terms of what audience we're trying to reach during concussion evaluation. As athletic trainers, we work with athletes all day. The likelihood that an athlete is going to voluntarily come out of a game or come over to you on the sideline and say, hey, something happened is low. So we need to make sure that we're educating athletes, parents, and coaches primarily on what to look for, kind of how to address concussions and what to kind of report and what not to report. Now, some of the uncommon ones that we're going to talk about during today is employers, right? Athletic trainers are starting to get a bigger role into the industrial side. It's an area that our National Athletic Training Association has focused a lot on here recently. And that means, you're going to be involved in concussion management from an injury perspective on an injured worker. Public perception and public knowledge of concussions is very low. Most of the public perception on concussions comes from sports. I got hurt in the NFL. I got hurt on Sunday. I'll play next Sunday. So when you talk about an injured worker where the forces are different, the requirements are different, and to be perfectly honest with you, it's a whole lot different than the NFL world. We have to make sure that we're educating employers. Teachers, admin, and school nurses are three that I kind of broke down individually, but they are all part of that concussion care team when it comes to a sports related concussion or a non sports related concussion from somebody that's in the school age. When we sit here and talk about concussion education, I've done a lot with going out to schools and presenting over the course of the last 6 years. And I can tell you the one common theme that I hear from a lot of the teachers, a lot of the guidance staff, and the administrators is how do we know somebody's got a concussion? What do we do on the education side or on the school side that they need to know or that they need to be involved with post concussion? So we need to make sure that we're including teachers, admin, guidance counselors, school nurses, anybody on the academic side that's going to be involved in kind of the day-to-day management of the injured athlete or the injured worker. They need to be involved in the education side as well. Now, this is where I'm going to kind of get a little bit of flack, but team physicians, primary care providers need to make sure that we are updating them on changes in the concussion research world. As an athletic trainer, we're supposed to get 50 hours of continuing education every 2 years. That's great. You can take a needs assessment, you can go through all this different stuff, but nothing dictates where you get your education from or what you're getting your education in. Same thing happens with every medical provider out there. They have certain amount of hours that they have to have for their general license and then certain amount of hours that they need for their specialization. Especially in a rural setting, if you've got a primary care or a pediatrician who's in charge of seeing a large number of patients across all ages, the likelihood that they're up to date on every single aspect of every single injury and every time something new comes out is very, very low. The challenge when it comes to family medicine is you have to know everything about everything. And when new research comes out, if they're not giving or being provided with that education, some things can slip through the cracks. So when we talk about education and concussion education, we need to make sure that we're including our team physicians and primary care providers in the area. Now, that's a lot. Right, that's a lot of different things that could potentially, education-wise, a lot of different groups of people that have a lot of different, understanding and different backgrounds and a wide variety of understanding of the medical field. So how do we reach all of those people? Presentations are number one, right? They're the easy one to do, and they don't have to be formal. Most concussion education happens preseason practices. If you got a team meeting coming up before your seasons even start, whether you're a secondary school athletic trainer, working at a professional level, at the elementary school or club level, we have informal presentations every single day. As an athletic trainer in the secondary school setting, a lot of times you're in those post-practice huddles, you're in the pre-practice meetings with coaching staff. It would take, 2 or 3 minutes to say, hey, look, this is something I want to talk about, something that we need to cover preseason to kind of get an idea that they're on the lookout as athletes and coaches and kind of providing the updates to changes in concussions as a whole. It's also a best way if we're doing formal presentations to meet, the bigger audiences, right? Most of the athletic training staffs in our area have a meeting at least once a quarter, if not once a month, where they go through some continuing education. Updating a large group like that through a simple presentation is very, very easy as long as you plan ahead. I know that teachers, administrators, school nurses, they have professional development days that happen again every quarter, if not every month, where, somebody like me, I come in and I present at those meetings. I come in and I try to update, the education side, what the return to learn protocols look like, and, trying to provide updated information to student athletes and the caregivers that are in charge of, coordinating day-to-day education. The second easy way to do things is handouts, right? Handouts, old school. I'm an old school person. I love paper. Transitioning to a 100% virtual world has been challenging for me because I still like to write things down. I still like notes. I like physical copies. I don't read digital books. I need hard copies, right? But when I talk about handouts, they don't necessarily have to be physical handouts. The world of social media that we have, TikTok, Instagram, Facebook, X, Twitter, whatever you want to call it, YouTube videos, those handouts are basic pieces of information that we can give out, right? Carousels, infographics, PDFs, the way of kind of presenting handouts has changed. Big schools, big teams, your professional sports teams, you use communication software like GroupMe or WhatsApp or Slack to communicate back and forth. as the athletic trainer and sports medicine staffs, you can get onto those kind of group challenge or group communication systems and push out kind of long-term or big messages, right? Push out those infographics, push out those handouts to the different groups to make sure that they have those things available to them. And the third one is webinars, right? I do webinars once a month to kind of update people of different walks of life, right? The first time we did a webinar series, it was a broad kind of topic on concussion and what concussion rehab is. This month I'm kind of curtailing it down into the role of athletic trainers in concussion management. But the goal of a webinar is that not only do I have the live version that I can push out on my social medias, it's also recorded on our YouTube videos that people can go back and watch at their own time. I will be perfectly honest with you, right? Nobody cares about concussions until something happens, right? Nobody wakes up in the morning, first thing in the morning, especially as an athlete or a worker, and goes, you know what, I'm probably going to get a concussion today. I need to make sure I know what's going on, right? They don't wake up and go, I'm going to slip on some ice and fall down, or I'm going to get into a car accident on my way to work. They don't think about those type of things. And to be honest with you, in the sports medicine world, I've always thought about concussions because I've liked how the brain works. And, since I started my sports medicine journey back in 2009, I fell in love with kind of how the brain works and the way kind of injuries and concussions occur. So I think about it a lot, right? I think about an athlete running down the floor and there's a ball in the middle of the floor. My first thought is not, oh man, we're going to tear an ACL or an Achilles if we step on that ball. My first thought is, okay, if they hit their head, what's going to happen? Okay, but most people don't plan for concussions. So having information available, especially digitally, having available information that they can go back to and pull in when something does happen is a key kind of part of the concussion education world. And it's a lot of times when the sports medicine staffs are, setting up their preseason introductions, we all have, sports medicine pages that they can push out that they can have all this information on, whether it's a web page or a social media account. Okay, so when I talk about concussion education, the one thing that I want to make sure to kind of reiterate during this whole process is education doesn't stop, right? Not only is concussion information evolving over the course of time, that it needs to be constantly reminded. It needs to be put into the forefront. Companies like the Concussion Legacy Foundation, the Brain Injury Association of America, Concussion Now, they're putting out these commercials, these advertisements to make sure that they are kind of pushing the importance of concussions, but it's also a way that they can push out, the kind of ongoing need for concussion education. Okay. So, we know the preseason stuff, we know the in-practice stuff, the informal stuff, but when we talk about concussion education, we also have to continue the education after the concussion actually occurs. Following a concussion where now all of a sudden there's something that's happening to me, the athlete or the injured worker has questions, the family has questions, the employer has questions, the coaching staff have questions. We need to make sure that we're continuing to provide that education and continuing to provide that guidance moving forward. Once the injury occurs, the job of the athletic trainer and the role of the athletic trainer in concussion education is just getting started. When people come into my office, their primary frustration is nobody talks about concussions, right? If you go to a primary care or a family medicine office, you might get some educational handouts that may or may not be accurate. You may get some, kind of brief overview of like, hey, you've got a concussion, this is what we need to do. But nobody answers questions because of the way the American model and the way the healthcare model is set up. Right? You don't have time to devote an hour at a time or an hour and 45 minutes to each individual patient like I do because I specialize in it. When we start looking at kind of the education side of things, once the injury occurs, so many people have questions that are unanswered that they need to make sure that they're getting answers to. And as the athletic trainer, you are that kind of primary go-to for a lot of sports-related concussions in athletes' school ages. So I can go on all day about the education side, the importance of education, but the one key takeaway that I want to take away from, or can I provide to you for concussion education, from all aspects of it, is communication is key, right? Don't just assume that the people around you have the information or know what you're talking about or kind of what to expect, even if they've had a concussion before. Once you've seen one concussion, you've seen one concussion. Each individual concussion looks different from, whether it's the same athlete, whether it's a different athlete, whether it's the same mechanism of injury. Every concussion is going to present differently. So continuing to provide that education is very important. The second objective that I want to get into during today's webinar is what actually goes into a concussion evaluation and what concussion diagnosis looks like. As athletic trainers, you are in a very unique position. You're the only healthcare professional that is present from the time of injury all the way through completely returning back to their sport. And that is a kind of something that all healthcare workers, myself included, envy, because I'm getting all of my information secondhand. As an athletic trainer, you can observe everything, right? You can observe the hit, you can observe the mechanism of injury, you can observe how the athlete looked right after the injury. In the industrial setting, it looks a little bit different. You may not have eyes on during the time, but you are the immediate report, right? You are the first person that they come to right after the injury, right? And that's where you start the dictation of kind of where, what needs to happen from the injury or the injured worker side that is very similar to the athlete side. You start the triage of it. But what actually goes into the evaluation and diagnosis, and what should go into the evaluation and diagnosis? So the common key things that we look for is kind of twofold. There's a subjective component, and then there's an objective component. When I start looking on the objective side, the first thing the athletic trainer needs to be involved in or needs to be aware of is what the mechanism of injury is. And the reason I harp on it and put it down here on the common causes of mechanism of injuries is twofold. Number one, it's a hit to the head or the body. You don't have to hit your head to sustain a concussion, right? Just because you have an athlete that comes off the field is like, man, I didn't hit my head, I'm good. That's not the case, right? A hit to the body, a hit to the shoulders, any change where there's a rapid deceleration of the head and neck can cause that shearing force to occur inside the body. That's also why I add on here a rapid jolt of the body, right? A rapid change of direction, a sneeze, a car accident where you don't have an injured, you don't have I didn't hit my head on the windshield or I didn't hit my head on the quarter panel, the airbags didn't go off, doesn't mean that there's not a concussion there. So we need to make sure that we understand what the mechanism of injury is. In terms of a loss of consciousness event, a loss of consciousness event, a LOC, is a medical emergency, right? Anybody who sustains a loss of consciousness event should be evaluated in an emergency department just to rule out any major significant kind of life-threatening injury, okay? As the research kind of changes and evolves, it may not be a rush to the emergency room right away, but more of an evaluation on your end of things. But if you have somebody who has a high Glasgow coma scale, somebody who reports a loss of consciousness, we need to make sure that we're referring to the emergency department. The shake, the SHAAKE. The shake, if you haven't heard of it, is something that was a research study that was done by the Concussion Legacy Foundation. The shake is an acronym. The shake stands for a sudden head shake after a kinematic event. SHAAKE. What that means is they did a research study that talked to and evaluated multiple athletes across different sports and asked if they shook their head immediately after hitting their head or not. They watched videos, they talked to athletes, they went back through and did an evaluation on whether or not an athlete who was in a head-to-head collision shook their head right afterwards. Their research study, although a little biased because they're researching and they're talking to people who have been diagnosed with a concussion, their research says that a significant number of athletes reported shaking their head immediately after the injury and then were diagnosed with a concussion, whether it was an immediate concussion or diagnosed with something down the road. So if you observe an athlete going head to head, whether it's in football, basketball, gymnastics, their head hits the floor, their head hits the diving board or the pool wall, and they come up out of the water or they come up off the floor, and the first thing they do is shake the cobwebs out, they need to be evaluated immediately. The last thing that's kind of common for athletic trainers to find and what you can observe is stumbling or disorientation immediately after the event. Most athletic trainers, we've observed this to some extent, right? An athlete will get hit, it'll be a big collision, they'll kind of get up, they'll come to a knee, they'll slowly stand up, they'll sway a couple seconds, and then they'll wave you off, right? That is something that in a perfect world needs to be evaluated immediately. Okay, as an athletic trainer, I understand the difference between the perfect world and the real world. Concussions and head injuries is one thing that you do not play with. Right, so if I have somebody who stumbles, who takes a knee once they get hit, who comes up kind of staggering and slow, they need to be pulled off the field and they need to be evaluated immediately. What evaluations can we do? The objective testing, the better technology gets, the more you're starting to see objective testing change. And what I mean by that, you've got companies like Impact Test, who's been around for a long time, the computer-based test that we can administer in a quiet environment, one-on-one, one on a lot, but that impact test has been around for a long time. Now, as technology is getting more readily available, we're starting to see changes where Sway Medical's coming in with an app-based kind of evaluation that you can do on the phone, right on the sideline in the locker room, that can be handled and administered relatively quickly. C3 Logistics is another company that has a digital version of their sideline assessment that can be done. The SCAT-6, it can be a PDF kept on the phone. There are different concussion companies out there, different companies and groups out there that have the actual editable PDFs that you can put on your phone that you can administer to somebody in real time. The King Devix test and the VOMS. The VOMS is the test, is the concussion evaluation that I use in the clinic virtually. Okay. The VOMS assessment is, in my opinion, the eyes don't lie. You can have an athlete all day telling you, I'm fine, I'm fine, I'm fine. But if they can't perform basic saccades, convergence and divergence, VOR testing and visual motion sensitivity testing, if they can't do those asymptomatic without observable objective abnormalities, they need to be removed from play. Okay. The King Devix test is an easy one that can be administered, especially if you're somebody who has limited resources, limited technology connection. We're out at a rural school, or in the factory. I don't have the connection to Wi-Fi that I normally would have. The King Devix cards that you can buy are a great way of evaluating somebody. All the objective testing in the world is great. The problem is there's a lot of subjectivity that comes to the injury. So we have to make sure that we're pairing subjectivity with objective testing, and we'll kind of cover that down the road. Okay, so like I said, pairing subjective and objective is very important, right? If I have an athlete who comes over and tells me that, hey, I hit my head, I have a small headache, but I'm good. We need to make sure that we're using the objective testing that we have at our disposal to ensure that they are quote unquote good, okay? If I have somebody who subjectively tells me they feel fine, but objectively they fail my testing, when in doubt, sit them out. We need to make sure that we're holding them out of play to be on the safe side, because the brain is something that we don't mess with. As athletic trainers, we know the importance of brain injuries. We know the importance of treating concussions, the way that they're supposed to. But we have all been in a situation that we have a parent or a coach really trying to pressure, or even the athlete really trying to pressure to get back on the field. Stand behind your objective testing. If something shows up on abnormality on the objective test, you need to keep them out. Okay, it's easy for me to say sitting behind a computer screen. I've been there, right? I've been in the professional sports world. I've been in the college world. I've been in the Division I and Division III athletics. I've been in the high school setting. It's very easy for athletic trainers to feel pressured to get somebody back on the field as fast as possible. I have yet to meet anybody who has regretted their kid, their son, their daughter, their friend passing away on the field, right? I have yet to sit here and say, oh man, yeah, that sucks they failed, but we lost the game. That sucks. No, hindsight is always 20/20. I have people who, have returned to returned to sport, injured and been like, hey, I really regret going back in and playing that game because I was injured because of all of this, but you have yet to meet that person who's like, you know what, John passed away, but we won the state championship, so it's kind of cool. That's not something that needs to happen. So when in doubt, sit them out. The third kind of key component that I look at is dual tasking. The new updates for the SCAT-6 have a dual tasking component. Sway Medical has a dual task component. The impact test, we have the ability to test multiple things at the same time. If I have an athlete who comes in and my objective testing is clear, I want to make sure that they can walk and talk and chew gum at the same time. I want to make sure that they can go through those dual task exercises, right? Counting backwards from 100 by 7, your serial sevens while standing in a tandem stance, walking while citing the ABCs backwards, doing a VOR kind of exercise while bending and standing up at the same time, making sure that they can do multiple things at the same time without provoking symptoms or finding objective abnormalities. The world is not done sitting down in a dark room or sitting in an office one-on-one. The world is done getting up and moving around, and objective testing and concussion evaluation needs to be done the same way. especially if you're borderline, whether somebody has one or not, you need to make sure that they can complete dual tasking exercises or dual tasking evaluations. A couple things to keep in mind when you're doing your concussion evaluation. Okay, not all concussion symptoms present immediately. As an athletic trainer, I've said it before, I'll say it again. In my role currently, I've said it, hey, you continuing to play was one of the dumbest things you could have done. As soon as you experience symptoms, you need to come out of the game, take a knee on the court, take a knee on the field. You need to come out of work to make sure that you're reporting these symptoms. Delayed onset symptoms are a very real thing. Whether we run into issues with, ongoing kind of care problems, or we run into issues with adrenaline being high, concussion symptoms may not present themselves right away. So if I have somebody who subjectively tells me I'm good, but objectively they're kind of borderline, hold them out, reevaluate in 24 hours, right? To make sure that we don't have any of those delayed onset symptoms. And if we have somebody who's continued to play, they come up to you after the game, they come up to you after their shift, they say, hey, Matt, I hit my head. I had a headache for a couple minutes afterwards. It's gone away. We need to make sure that we're bringing them back in the following morning, the following day, before they start their next shift or before they start their next practice or game, to make sure that we're going through another thorough evaluation to make sure that we didn't have any delayed onset symptoms. Okay. And I've harped on this enough, and I think I've kind of hammered the point home, is we need to make sure that subjective and objective things, we're getting both of those to match up. Okay. Taking a patient's word for it, clearing them based on them telling you, I'm good, I'm good, I'm good, puts your license and their life in a very, very, very dangerous position. We need to make sure that we are taking subjectively what they're telling us and proving it through objective and dual task testing. We all know in the athletic world, athletic trainers are involved in a lot of the initial evaluation for concussions. But when it comes to the industrial world, we are becoming more and more that kind of go-to healthcare provider and reducing kind of claims, right? Whether we're being a screening process for external referrals or we're a screening process for an internal kind of in-house medical staff, we need to make sure that we are staying up to date on what different tests are out there and making sure that we're providing a thorough evaluation, even if you have an injured worker or an athlete that comes in and says, hey, you know what? I'm good. We need to make sure that we're proving that they're good. Athletic trainers offer a unique role in bridging the gap. We've heard it a lot throughout the change in kind of the evolving role of athletic trainers in the sports medicine team, but athletic trainers are like water, right? We fill in everywhere. Right? You need somebody to fill in and cover this event. You need somebody to help out with that. You need somebody to lead strength and conditioning. We're good at being liquid. We're good at flowing through the different areas and the different gaps. Now, bridging gaps in concussion management is something that the athletic trainer has to take a role on as well. And the reason being, in the athletic world, the entire population that's in charge of kind of the concussion management runs from the athlete and their family, the coaches, the medical staff, whether it's you or your team, the medical staff, the guidance school, the staff at the school, the administrators, the school nurses, the teachers, and the big one, the teammates. We need to make sure that we are bridging the gap between all of them. I underline the teammates at the bottom because that is something that is a key kind of a theme with my concussion patients, right? The key theme is, my teammates don't understand, my friends don't understand, my coworkers give me a hard time. We need to make sure that we're keeping them kind of up to date, not necessarily on specifics for this important injury, but being the liaison and being that kind of in-between moderator when it comes to kind of bridging the gap in concussion management. On the industrial side, the key, the team sounds very similar to the athletic side. We got to make sure that we're bridging the gap between the patient and their family, in-house medical staff, external providers that may be involved in the management or diagnosis. And we need to make sure that we're keeping and bridging the gap between nurse case managers. If you've ever had a chance to work with a nurse case manager, they are very similar in their role in the medical picture to athletic trainers. Their job is to bridge the gap between the different parties involved in work-related injuries, right? They need to make sure that they're coordinating care with insurance companies, with the employer, with the injured worker, with all different parties involved to make sure that we are kind of bridging the gap. When we start looking at the industrial athletic trainer or the industrial setting for athletic training, The team aspect is very, very, very similar, especially if you have a factory setting or a blue collar setting. They're very similar to a locker room setup, right? They're friends. They give each other a hard time. They are there for them. They provide for them. They have different kind of rivalries, and it's very, very similar to the athletic world, which is why the athletic trainers have started to kind of slide into that realm because of the combinations, the similarities between athletics and the industrial setting. So we need to make sure that we're, keeping everybody in terms of the care team involved, but we also need to focus on those teammates and those coworkers. And again, one of the reasons I want to harp on, keeping that kind of teammates and coworkers in the loop is because of number 3 here on this list. We need to make sure that we're running interference. What I mean by interference is public perception is very, very dangerous to concussion recovery. Okay? If I have somebody who's taking a long time to recover, that bug in their ear, their coworker saying, well, when I had my concussion, I recovered in 3 days, or, you're letting the team down because you're not going to be available for the sectional championship. All of that will delay concussion recovery by draining the mental health of the injured patient or the injured worker. So we need to make sure that we are providing kind of interference when it comes to that. We need to write public opinion. If you're sitting in your athletic training room or sitting out at a practice or in a huddle, and you start to hear those comments that are being made on, they're out again, you look normal, oh, you can do this, but you can't be out at practice for us today. You need to make sure that as an athletic trainer, you're nipping those things in the butt, because your job is to advocate for your patient, right? If I'm not advocating for my patient when they're degrading him, whether to his face or not, if you're not advocating for that patient, the recovery timeline is going to be extended because somebody is not in a good mental space to recover from their brain injury. Okay? When we start looking at the bridging of the gap, don't assume everybody is on the same page. Okay? You know what they all say about assuming. When it comes to concussion care and bridging the gap in concussion management, the athletic trainers need to make sure that we are communicating. And by that, it's not always a verbal communication, right? And the easiest way to get all members of the concussion care team involved, especially when it comes to the academic side, set up an email chain that has everybody in your concussion care team all in one management or one kind of chat or one string, and say, hey, Johnny got hurt during practice today. This is where we're at in terms of our 5-step return to play protocol. This is where we're at in the return to learning protocols, to make sure that everybody is on the same page. The more communication, the better. As somebody who's been involved in a lot of concussion management, if there's something that is said to me or sent to me from a nurse case manager or from an athletic trainer or from a primary care provider that I don't need to know, it's really easy to ignore it. But if there's key information missing, if I've got multiple people involved or multiple therapies involved in the treating or the management of this concussion, I need to make sure that I have all pieces of the puzzle at my disposal, just like somebody on the guidance staff does, or just like somebody on the coaching staff does. We need to make sure that we're all on the same page during concussion recovery. The second one on this list is the changes that are occurring for concussions. Concussions are a very fluid injury. You have good days and bad days. You have good hours and bad hours. Everybody wants concussion recovery and trajectory to go, from bottom to top. I go from 0 to 100% fluid. There's no ups and downs. Realistically, concussions are a roller coaster. You're going to go up and down, and you're going to twist and turn and flip and go up and go upside down. There's going to be massive changes that occur during concussion recovery, and we need to make sure that we're communicating those changes through all parties involved. Okay, again, talking about concussion interference, I just want to reiterate the importance of mental health during concussion recovery. Not only metabolically is there a change to hormone structure, there's a change going on underneath that are affecting kind of concussions and concussion recovery. We also need to understand that external factors are going to play into that, right? If I have somebody who metabolically is dealing with a hormone imbalance similar to a depression, whether they had pre-existing depression or not, and now you add the court of public opinion and coworkers that are giving them a hard time, we run it, or teammates that are saying things to them, whether directly or indirectly, that is going to cause a downward trend in their mental health, and a happy brain heals faster, okay? The biggest difference between athletics and the industrial setting when it comes to kind of the mental health side of things and the injured worker and why athletic trainers need to be involved in running interference is we start looking at an employer who doesn't understand the total scope of the injury. Now we're looking at the livelihood of the injured worker, right? If they get terminated, now all of a sudden you've got financial stress, you've got emotional stress, you've got the fact that we've been terminated from a job that we've been at for a while, that we love, that we didn't like very much. It adds an external amount of stress, and that's going to prolong our recovery timelines and our recovery trajectories. So it's important for athletic trainers as a unit or as an individual to make sure that we are kind of bridging the gap and making sure we're communicating with all parties involved in concussion management. I've talked a lot about what recovery really looks like, okay? How do we determine whether somebody's recovered, how they've recovered, and then what the athletic trainer's role is after we've determined somebody's recovered, right? Concussion education, concussion treatment does not stop after a subjective and objective recovery. So what does that role look like to an athletic trainer? Okay? When we look at athletics in terms of what recovered really means, we need to make sure that baseline symptoms we've returned to baseline symptoms for a 24-hour span, okay? Notice that it says baseline symptoms, okay? Not everybody is completely asymptomatic, okay? For multiple reasons. Not every headache is just a headache, okay? We need to make sure that they have hit their baseline symptoms for a full 24-hour period, passed all objective testing, whether it's the VOMS test, the SCAT-5 or SCAT-6, your King-Devix test, your IMPACT or C3 logistics, or your SWAY medical testing, whatever objective testing that you utilize, especially during, preseason testing, during your injury, the initial injury evaluation, we need to make sure that we have passed all objective testing, that there's no abnormalities that are occurring, no symptoms that are arising during the objective testing. We also need to be asymptomatic during dual tasking. And what I mean by asymptomatic is no increase in those baseline symptoms. Okay, we need to be able to test to make sure the athlete is healthy enough to return to their sport without any changes in physical presentation, external signs of distress, or subjective reports and complaints. And then we need to be able to progress through that return to play protocol. Every organization now has some form of return to play protocol set in place. When you start the return to play protocol is different for each individual group. So we need to make sure that they are completing a guided return to play protocol. We're not just sending an athlete out in the wild and say, hey, for the next 5 days, this is what you're going to do, because we all know that's not going to happen. Whether it's communicating it with the coach, the organization, the GM, the strength training staff, whether it's communicating it with a different party or overseeing that return to play protocol itself, we need to make sure that every injured athlete is going through a formal return to play process. On the industrial side, what recovery looks like is we need to make sure that, again, we're baseline symptoms for 24 hours, we've passed all those objective tests, and we need to make sure that they're working their normal work status without symptoms before we talk about total recovery. Now, as athletic trainers, that's not your call to make, right? As athletic trainers, if we have somebody on work restrictions, that's coming from somebody else involved in that, in that recovery team, whether it's coming from, a nurse practitioner or PA on staff or in-house medical staff or a medical director, or it's coming from an external provider. But in terms of total recovery, the employer is going to want to make sure that they can work their normal shift without getting any symptom increase from a liability perspective, right? If I have an injured worker that their job is to drive a forklift and we've cleared them in terms of like, hey, you're completely released, without restrictions, we need to make sure that they can drive that forklift without getting dizzy and disoriented. Because if they take a life, not only is it going to come back on the factory or come back on the employer, it's also going to come back on any medical provider that's been involved in that return. So we need to make sure that we're testing the limitations that we have set in place based on what their job duties look like. I want to go back and talk on a couple different things. During the return to play protocol, exercise intolerance is a very real thing. The reason that we talk about physical activity during concussion recovery, going through a guided return to play protocol, is because exercise intolerance may not present with symptoms immediately. You may have an athlete that goes through your return to play protocols or goes through your physical activity and is like, you know what, I feel great. I feel fantastic, no problems. And then 20 minutes afterwards or 2 hours afterwards, now all of a sudden they get headaches and dizzy. They may not report that to you. That's why we need to make sure that we're monitoring multiple times after we've put them through that follow or through that physical activity or what that kind of guided exercise looks like. You know, I give athletes and I give patients the benefit of the doubt a lot. Okay. Hey, how did you do during your testing yesterday? How did you feel after our appointment yesterday? It's a very open-ended question. And then I'm going to go specifically, hey, did you get any headaches? Did you get any dizziness? Because they may not attribute the headache that they got 3 hours after the exercise to the actual injury in itself. It may not be related, but we have to make sure that we're going through and we're actually evaluating that to see where the cause of that, that headache or where the cause of that nausea came from. Was it dehydration or was it autonomic in exercise intolerance? Once an athlete's return to sport, there is a higher risk of lower extremity injury for up to a year post-concussion diagnosis, right? So once the injury's been sustained, for up to a calendar year, even after an athlete is perfectly asymptomatic, they're back to play, they have no restrictions, they are at a higher risk for lower extremity injury for up to another, for a calendar year after the injury date. As athletic trainers, we need to be aware of that risk, right? One of my final kind of follow-up evaluation, follow-up conversations with athletes is, hey, you're right now like a car driving down the interstate, right? That injury risk is there. You're allowed driving down the interstate and you got a wobbly wheel on your tire or car, right? If I roll an ankle or I pull a hamstring, I now have 2 wobbly wheels on my car, where normally I'd be like, hey, that's no big deal. Now I'm driving down the interstate with 2 wobbly wheels. I need to make sure that I'm doing things to get those small nagging things taken care of. As athletic trainers, we need to make sure that we understand who in our teams have had concussions in the last calendar year. And those minor things need to be addressed. Because if I have 2 wobbly wheels on my car driving down the interstate, I now run the risk of losing control, right? So if I have somebody who had a concussion 6 months ago and now they're dealing with a grade 1 ankle sprain, where normally it's like, hey, it's no big deal. Now all of a sudden we don't have the same speed of our vestibulospinal reflex. We have limited or compromised ligament structure, compromised muscle control of that, neuromuscular control of that lower extremity. We may run into a situation where now all of a sudden we're primed for an ACL tear or an Achilles rupture or hip labral tear. We need to make sure that we're addressing that. As the athletic trainer, the athlete's not going to know that. So when it comes to the role of the athletic trainer, we need to make sure that we are kind of keeping an eye on what happens after the athlete returns to play. The final one is the fatigue factor, okay? There is a lot of research that's been done on the neurometabolic cascade post-concussions. And one thing that they are finding is it takes a minimum of 30 days from the time an athlete gets hurt before the brain is back to its normal neurometabolic function, okay? That's leading to a lot of kind of headbutting when it comes to when we return an athlete to play and when we don't. There are a lot of people in the brain injury research world that are saying, hey, we need to hold somebody out for a minimum of 30 days. Okay, because metabolically, no matter what they're telling you symptomatically, metabolically, the brain is not back to its normal metabolic function. So when we start looking at that, right now, the gold standard is still subjective reports of return, complete my objective testing without abnormalities, no symptoms during the return to play protocols. I can't hold them out for longer than what's expected. But when we talk about the neurometabolic cascade post-concussion, this is what we're talking about. The neurometabolic cascade post-concussion, we're talking about the ATP production that happens inside the brain. That yellow section right here, this yellow kind of structure up in the very top, right? When somebody gets injured, if we're looking at time of the injury, right? Once somebody gets injured, there's a massive influx in energy demand that occurs. That massive influx in energy demand, the calcium and the sodium going in and out of the cells to cause that disruption, cause the electrical storm that's occurring. That usually takes anywhere from 0 to 48 hours. Okay, so there's a massive change in energy demand in that first 48 hours. And then after that, the energy level and the energy production tanks, right? The brain stops its production of ATP over an extended period of time. And then as the brain heals, it will slowly increase its energy production back to its normal baseline energy level. Again, that neurometabolic cascade usually takes up to 30 days minimum, right? I say minimum. Sometimes recovery timelines take longer than 30 days, right? We look at, kind of injury recoveries as a whole, they're very individualized and they take a while. So when we talk about the neurometabolic cascade post-concussion, the reason we take it so serious when we have athletes under the age of 18 is if I have somebody whose energy and ATP production are very low, and this is the baseline level, the bottom of that graph is the baseline level that we need for a brain to function. If I have another rapid influx of energy demand and then another energy dip overall, that's where the fatality rate goes up in second impact syndrome, is because the brain no longer has the energy production, the body no longer has the energy available to keep systems alive. So when we're talking about, post-recovery and determining what recovery really looks like, recovery is very individualized. The research tells us that 80% of people should get better within the first 30 days, okay? That 20% of people is the reason the clinic exists, right? Now the more research coming out tells me that I need to be involved at the very beginning, but the reason we do rehab is because there are still 20% of people that don't get better within that first 30-day window. And the more research that's coming out, the more research tells us that everybody needs a graded, kind of guided rehab plan and return to physical activity and return to day-to-day activities starting at day one. But in a perfect world, I'm not getting people to come in on day one, right? That's where the athletic trainers are involved. We need to make sure that we are establishing that strict kind of return protocol and what recovery actually looks like from, the 0 hour all the way through their return to play. As athletic trainers, your job is to be that primary source of education, that primary source of guidance to ensure that we have people that are doing what they need to do during their concussion recovery from the very beginning all the way through their returns. The other thing that I want to touch on with special considerations is baseline symptom does not necessarily mean asymptomatic. I touched on it a little bit earlier and I want to kind of reiterate it now. If I'm having somebody fill out a subjective questionnaire, whether it's the post-concussion symptoms checklist, the dizziness handicap index, the headache, the headache score indicators, or the daily headache index scores, I need to make sure that I am relaying that we're looking for anything that's outside of your normal, right? If I have somebody with a history of migraines, I've worked with a lot of concussion patients who have history of migraines, and I can tell you one thing is common through all of them. They can tell the difference between what a migraine headache feels like, what their chronic headache feels like, and what a concussion headache feels like. So just because I have somebody coming in telling me, hey, my headache's a 2 out of 10 today, I'm having a great day, I can't take that 2 out of 10 and say, well, you're out because that's a 2 out of 10 headache. Well, you need to make sure that you're communicating with them. Hey, what's your baseline headache? What's the baseline dizziness or nausea that you have? What's your baseline fatigue level look like? To make sure that we're getting a proper representation of what the injured worker, what the athlete really kind of looks like in terms of their overall day-to-day kind of symptomatology. The role of the athletic trainer is very, very unique across the entire sports medicine world. But when it comes to concussions, the role of the athletic trainer is much more broad and much more in-depth than even some athletic trainers realize. So I'm hoping that today we learned that, concussion education and awareness is something that needs to occur not only prior to the injury, but throughout the entire injury process and after somebody has completely recovered. What the athletic trainer's role is in concussion evaluation and diagnosis, the fact that we need to do subjective questionnaires, objective testing, and dual task components to evaluate the concussion as a whole. I also hope you learned that you were able how athletic trainers bridge the gap between the different people involved in the concussion care team, from the academic support side, from the employer side, and from the family and friends side. And I want to make sure that you understand what the roles are of the athletic trainer in determining subjective and objective recovery and what needs to occur after subjective and objective recovery. Okay, whether it's the continued focus on strength and conditioning, the continued focus on monitoring and treating small, minor injuries and musculoskeletal deficits, and the fact that education resumes back after somebody's gone through the return to play protocol, and we kind of re-perpetuate that cycle of education. Again, thank you guys for watching. My name is Matt Campbell. I'm the owner of the Midwest Concussion Clinic. Every third Wednesday of the month at 12 Eastern Time, I like to do a webinar series. So if you're more interested in kind of differences in concussion management, what kind of concussion, the world of concussion looks like, Follow along on our social media accounts. We've got Twitter, Instagram, X, Instagram, TikTok, our YouTube channel. We're at MW Concussion or the Midwest Concussion Clinic on Facebook and YouTube, but at MW Concussion on the rest of them. My personal philosophies in life is, if I've got a special talent or really an obsession, if I have information, my job as a person is to share it with somebody else. So if you've got a specific question about something you need help with, shoot me an email. The phone number's up on the screen. We've got our office number. Feel free to call or text that. Shoot me an email. I'd be happy to talk to you. But as always, thank you for watching. Thank you for joining along in the virtual Midwest Concussion Clinic's journey. Join us next Wednesday or next month, the third Wednesday of next month, where we talk about our next webinar series, and that topic I'll figure out and I'll present and push that out to you guys here down the road. Thank you for watching. As always, good luck. I hope I never have to meet any patients that I deal with, but if you need help, you know where to reach me. Thank you.